Good evening, everybody. Welcome to the webinar. It is Tuesday, October 27th. And tonight I want to talk about mood disorders a little bit in terms of my description. But I think, like all of these webinars, most importantly, what's our participation as parents? What can we do to be helpful in the process? And what do we do or what are we inclined to do that might not be helpful in the process? So that's really going to be the emphasis, but I'll give a little bit of background. And the language around mood disorders is changing these days with new diagnostic uh, requirements. So there's some language change that's going on right now, but I'm going to speak about it from a very general perspective when I talk about the specific diagnostic labels, because what we believe about the disorders is virtually the same. It's just that the way that they're coded these days. What are the most common questions that people ask me about mood disorders? The first one is, what is the cause? And we know that there's an organic predisposition to mood disorders. We know that. We know that from the research. We know that the way that the brain processes and the chemicals in the brain, that a child is born with certain features, qualities, propensities, right? Different amount of serotonin and dopamine are produced in various individuals. And so there's a predisposition there for inflated or deflated moods. We know that. And that's one of the reasons why medication can be a helpful part of treating mood disorders in most cases. We also know that there's an environmental and trauma piece of it. And that doesn't have to be big T trauma. I think a lot of people, when we hear the word trauma, we think of something dramatic. It could be the normal traumas of growing up. Being embarrassed in school about something you said or did can be a trauma. Right? Being made fun of can be a trauma. Being yelled at by a parent can be a trauma. And those are what we call small T traumas, and we all experience those. And this is something else we know. We know because of our ability to scan brains that trauma affects the brain and the way that it looks and the way that it functions. And so when people talk about it being chemical or being environmental, it's not all that clear of a line, because trauma affects brain chemistry and changes the way that a brain functions. So it's kind of a chicken and the egg question when you talk about it. But a lot of us are going to look at what's under our control and the ability to treat it, and how can we uncover or unpack that trauma. Part of it can be affected developmentally by the hormones, by what's going on in the individual. Life stages can affect trauma, right? There are certain challenges of adolescence and pre-adolescence. There are certain challenges of middle age and older adulthood that cause stress, that lead to difficulties with being able to have a positive mood, a flexible mood. So that's something that we know also. In adolescence, mood disorders are often misdiagnosed because they come out as angry and defiant. And what we know about mental health now is that as the child moves into adulthood, a lot of times they move from an angry, defiant, right, acting out kind of behavior to a depressed, acting in kind of behavior. So, and sometimes some of the elevated moods can be misdiagnosed for other things too. That manic mood can be misdiagnosed to mean something else, impulsive or addictive. Although there's like I'll talk about tonight, there's some overlap. There are behavioral aspects of depression. What I mean by that is that there are, and I'll talk about secondary gains, right? There's this dynamic, there's something we get out of our mood disorder, so it gets reinforced in our environment at times, right? A person who becomes depressed, for example, is often looked upon with pity. The bar starts to be lowered. They hold people hostage because there's always a threat of hurting themselves or giving up or losing motivation. And we as parents interact in such a way to reinforce that. We do that inadvertently, of course. And as primary gain is, what do I do that relieves some anxiety, right? So if I bite my fingernails, the primary gain is I'm spending energy and focus, and I'm having an anxiety reduction if I'm biting my fingernails. The secondary gain is, what do I get in relationships? So if I get negative attention from my father for biting my nails, I'm getting attention from my father for biting my nails. That also is a gain, a reward, a reinforcer in this example, in this case. So there are primary gains, things that cause us to reduce our anxiety, and secondary gains are things that we acquire or get out of the behavior in relationships. One of the common interventions I would often use for depressed people is I would say, let's write a paper on your depression. And this paper is going to be kind of like a love letter, like talk about what you love about it, talk about how it benefits you. And most people are entirely reluctant. But part of what I'm getting them to shift is to understand There's chemical, there's behavioral, there's trauma, but there's also some things in our environment that reinforce that process. And there's also a piece about that is compassion. And if we can look upon our anxieties and our depression and our mood issues, if we can look on those things with compassion, we're much more likely to heal them and deal with them than if we look at them with disgust or look at them as something that's just got to get over. Um, I think a lot of parents want to find the cause, right? They want a package with a bow, right? I was just talking to some parents today. You know the old adage of giving a person a fish and teaching them, excuse me, feeding them for a day versus teaching them how to fish and feeding them for a lifetime? The individual with the mood disorder, part of the healing, the opposite of it is learning how to feel, right? And I'll talk a lot about that tonight, learning how to feel. And so it's not just one thing that causes it, it's a way of relating to the world. And I said, best case scenario for most of our clients, the worst things in life haven't happened to them yet. That's the best case scenario. Because then what that means is that they've fallen in love, that they've had love. And along with love comes heartache and heartbreak at times, and we're going to lose people that we love. So we're going to teach your children how to fish rather than finding the big fish for them, which I think gives parents, if they can identify, maybe it's the adoption, maybe it's the divorce, right? If they can find out what that one thing is, then there's a sense of control over it. But this is a process focus, right? How do you feel and cope with trauma, with pain, with sadness, with loss? How do you cope with it is the thing going forward. So that's what we teach. Oh, I spelled evoke wrong. There's going to be a few typos tonight because I didn't get these proofed and I'm a horrible proofreader. What a funny thing to misspell, excuse me. What is the cure for depression? First of all, at Evoke therapy programs, our policy is to typically, our default position is we're going to stabilize the medication that the child was on prior to entering Evoke. We're not going to make any changes. We don't want to change too many variables. If you change 4 variables and you see improvement or a lack of improvement, you're not sure which one it is because you've introduced 4 new variables. So our default stance is whatever the child came in on is what we're going to stick with, right? That's our baseline. As therapists move through the process with your children and in conversations with you, we will look to our psychiatrists to make adjustments to the medication, to reduce medication, change medications, or start or increase medication. So we'll do that after we have some baseline and some. If the parents and the child are very, very sure from the outset the medication has been off, we can do that earlier on in the process. But that's our default position. And our belief also is we're not pro or anti-medication. We are open to whatever the child needs. And we know that medication helps. I like to think of it with the mood disorders, it helps people get out of the starting gate. Right? Some people can't even get out of the starting gate. Another way of thinking about it is if you can't access therapy because your mood is too low, because you're too dysregulated, you can't listen, you can't hear, you're not willing to try anything. If you can't access therapy, make use of it, then you need medication to be able to make use of the therapy. And most studies will show you that exercise, therapy, and medicine are an important part of treating mood disorders. I put therapy ... because there's lots of therapies, right? Typically, cognitive behavioral therapies and dialectical behavioral therapies, because they have specific skills to help manage mood dysregulation, specific concrete things, those can be helpful in the process, but it need not be limited to that. Family therapy can be helpful. Therapy that goes back in history and understands trauma and where it came from can be helpful. EMDR can be helpful. A lot of things can be helpful. 12-step work can be helpful in helping somebody deal with feelings and situations. Mindfulness is a lot of what we do at Evoke. Mindfulness can be helpful in managing mood dysregulation. So there's a lot of approaches to it. Communication theory, that's tied into the cognitive behavioral. Understanding our thoughts, because our thoughts are what cause our feelings, right? Our beliefs or interpretations about life are what cause our feelings. So communications theory can help one understand the relationship between what happens in one's life, what one thinks about it, and then what one feels about it. Exercise and diet, sleep are all important parts of it. That's inherent in the Evoke curriculum. And then, of course, family therapy, like I said, looking at the system. How does this depression serve the system? How is it getting reinforced in the system? What patterns can we break? Because you're going to be with them in one capacity or another for the rest of their life, for the rest of your life, excuse me. You're going to be with them in some relationship. And so we can give the family tools to be helpful going forward. Then that's a fantastic contribution. And sometimes the question is, is it normal? Is it normal stuff to feel this? Because sometimes people, we use the word in our culture, depressed. I feel depressed when we mean sad or overwhelmed, right? So that's part of what can happen is you get an assessment about kind of a perspective from a professional to answer that question. Depression, dysthymia, bipolar, or manic depressive disorder are all mood disorders where the individual is unable to manage emotions or participate in one of several spheres in life. That means work, social, school, if they're in the school age, health, relationships in the family. If there's some areas that are getting affected, that's what defines it as a mood, or if it's getting in the way of functioning in one or many of those spheres. Several spheres of life due to mood swings, motivation, or unstable patterns of emotions and associated behavior. Severe mood disorders can be triggered or the result of trauma, and can be triggered or result from substance abuse. So substance abuse changes the amount of dopamine in your brain. Your body stops producing it, and then your mood is going to be depressed. It's going to be low because you've been taking a chemical to make yourself feel good, to give yourself relief from anxiety. And so your body stops producing what it needs to. You become addicted to it and can look and be in a depressed state. Mood disorders are often associated with substance abuse and considered comorbid. The insidiousness of the issue is confounded because the sufferer often exacerbates the problem by isolating, inactivity, alienating behaviors. That means pushing people away, and poor diet and sleep habits. So the very things that are the symptoms of mood disorder, specifically depression, are the things that cause it to be worse. And so those of us from the outside, we look at somebody who's depressed, who's shut in, who's not going out, and we start giving advice and suggestions about what they can do. And it's important to understand that's all the stuff they don't want to do. And then some of them can even be aware of it at a really overt level like that. So again, it requires our compassion and our patience in the process, and then healthy boundary setting in our lives in relationship to that person. The sufferer experiences learned helplessness, meaning that nothing I will do will make a difference. The problem is outside of me. And I am either ineffective or ineffectual, or it's just not going to make a difference. I can't change the thing I need to change. So again, there's a lack of motivation or even belief around doing anything. Oftentimes, people that struggle from depression will have kind of a I'm damned if I do and I'm damned if I don't. If I assert myself in this relationship, if I ask for what I need, I'm going to hurt the other person and I'll feel horrible about that. If I don't ask for what I need or don't assert myself, I'm going to feel horrible about myself. So either way. So part of what helps us as professionals and as parents to help them unpack it is giving them space to talk about anger and hurt, resentment, right? Giving them the opportunity to make it overt, to act it out, and also helping them deal with the risks, the fears of taking those kinds of steps. Carl Jung said neurosis is a substitute form of legitimate suffering. And the reason I have this quote on here is because although he's talking about neurotic behaviors, I'm talking about mood disorders, the same principle applies. It's not legitimate, authentic suffering. That's something that we need. That's something that is connected to our love, to our bliss, to our relationships, right? Suffering is a part of life. But neurotic behaviors or symptoms in mental health, eating disorders, I'm going to talk about that on Thursday this week. All of those are inauthentic ways of suffering. There's still suffering going on there. But it feels better, less painful to inauthentically suffer than it does to authentically grieve and experience pain. So that's part of what it serves in ourselves. So let's talk about pain. Even non-diagnosable children are hard, right? I mean, that's just, it's true. So I think sometimes those of us, and I being one of them, who've had children with mental health issues, addiction issues, and we're challenged by that. But even those of us also, in my case, who have children that aren't diagnosable, aren't at a clinical level of mental health or addiction issues, even those children, they they're hard too. They're a challenge. I saw a quote today that said, there are perfect parents in the world, they just don't have any kids yet, right? So part of what we can offer each other is empathy, understanding, and compassion as we go about this. Our experience of being alone as a sufferer or as a family member of a sufferer, right? You've heard the phrase that the problem is that you're comparing somebody else's highlight reel with your behind the stage footage, or somebody else's, you're measuring your insides by other people's outsides, is another way of saying it. So we have this feeling. Everybody loves somebody who has struggled with mental health or addiction, right? I've not met anybody who doesn't have somebody they care about that has these problems. So part of talking about it, part of coming out to your therapist, part of coming out to the group that you might be participating in can be helpful. There is a certain chaoticness to, for example, manic depressive, right? There's highs and rapid cycling highs and lows, and there's something that feels like a wonderful rush to those kinds of behaviors. Those are hypersexual, hyper shopping, right? Inflated sense of self. That's what that manic piece is about. It can even get to the point of being psychotic and delusional, and in many cases is. But there's something, again, there's something gets stimulated, especially in the adolescent, young adult brain, that gives them some kind of rush, right? They require, the young brain, the 25 and younger brain, they require more stimulation to feel a thrill than adults. We know that about the brain. And so some of this stuff that occurs around these kind of unstable relationships, breakups, serial random sex, all these kinds of things, these have qualities with them that come along with them that are chaotic and dramatic. And there's a thrill that comes along with that. Part of what I ask parents to adjust to when they get a diagnosis that their child has depression or bipolar mood disorder is to say, you're going to have to adjust to this new norm, right? Nobody wants it. You deserve empathy, compassion. But part of what you can do is lean into it and embrace it and say, there's certain things. It's like having a child with, right, a physical disability. This is something that you're dealing with. And it can teach you, and it can provide wisdom and meaning for you. But there's definitely going to be an adjustment where you have to back off of holding on to the outcome and trying to control it, and believing that if you press all the right buttons perfectly, that the child's going to snap out of it. They are burdened by that belief, and you are burdened by that belief. Learning to value the struggle, right? That's a huge piece of the parent curriculum at Evoke. It's the principle from dialectical behavioral therapy of radical acceptance. Like, this is what it is. We have this in our family, and I can keep wishing that it wasn't. I can keep resenting this detour and being upset that it's in my life, or I can make meaning out of it. I can develop new skills. I can do some of my own work. I can learn to communicate, listen better. I can learn to be assertive. I can learn about self-care. I definitely can develop deeper compassion for myself and others through this process that is a struggle. So learning to assign value to the struggle instead of just disliking the struggle, wanting it to go away. Like I said, there's a change in lifestyle. It's a new diet. It's not a crash diet and it's over and you arrive. It's a new way of being in a relationship with your children and with the world. Going to support groups like the ones that I mentioned at the end of every webinar. You can also go to support groups specifically by contacting therapists in your area, and some of them will have men's or women's groups or parents with children who are struggling. So you can find out information from your local professionals in that area. But going to therapy is a huge help. As you know, I'm a big fan. Learning to take care of yourself and learning to let go of the guilt. We don't have to feel guilty and shamed to change. In fact, those are barriers to change. We can just look at it without judgment about what's our participation in this issue. How have we participated? I don't have to beat myself up for it or feel badly about it, but I can look at, do I want something different? Do I want to participate in a different way with my child around their problems? I have so many parents that will say to me, but my child doesn't do drugs and alcohol. My child is just anxious or depressed or has Asperger's or what have you. It's all the same principle. There are uniquenesses to each diagnosis. But the common thread of all of them is you're in a relationship with somebody that you love more than anybody who's participating in a self defeating lifestyle, self defeating choices, self defeating beliefs, self defeating symptoms. And what's your relationship with them? Do you feel like you caused it? Do you think you can cure it? Do you become obsessed with it? Do you try to control it? All of those kinds of questions are what we learn, what we ask ourselves in order to learn how to be in a healthy relationship with an addict or a depressed person. And be wary, especially in a condescending, judging, impatient way, to apply your logic. You know, talking to a depressed person is like talking to a drunk person. That's not rational. And oftentimes the parent is not the best one to teach them because you can get overwhelmed a lot easier, a lot quicker than a professional, than somebody else who has more detachment from your child. And you can also present more of a threat to your child, meaning that they don't feel safe. They feel like they're being judged by you, right? You're trying to smother them, looking over their shoulder. So that's why we all need help outside of the family, because others who don't love our children as much as us, but can be more clear with them in terms of their boundaries and even their being able to see them, can be more helpful and more effective. This is from my book. I realized that my job was not to make people happy, but to help people feel sad. My intent is not to inflict injury or cause pain, but to help people to feel. It is my job to help others learn how to feel their pain and sadness in order to rid themselves of paralysis and moving forward. Ironically, I realized that much of the wisdom I had to offer people was forged from the pain I felt growing up. It was not my job to take away a person's chance to learn and find meaning in their suffering. Viktor Frankl wrote in his harrowing memoir of Auschwitz that trying to find happiness was the sure path to meaninglessness and unhappiness. Rather, it is our task to give suffering meaning and learn from it. This process ascribes value to it. As Thich Nhat Hanh explains, many people aspire to go to a place where pain and suffering do not exist, a place where there is only happiness. This is a rather dangerous idea, for compassion is not possible without pain and suffering. It is only when we enter into contact with suffering that understanding and compassion can be born. Without suffering, we do not have the opportunity to cultivate compassion and understanding. And without understanding, there can be no true love. So for all of us, what this can do, what this practice of what this talks about can do for us, is we start to have a different relationship with our child and their symptoms. A more loving, in therapy it's called, we provide a safer container. The container being the mind of the parent. We start to relate to their symptoms differently. We develop courage to be able to be proactive and not knee-jerk. We develop capacity to become more flexible. And that's because we're not afraid of it, we're not overwhelmed by it, we're not running from it, we're not trying to control it. We're trying to hear it, listen to it, love it, and then make decisions in our life that are going to be most helpful for us and for others around us. Start to identify the primary and secondary gains. Like, what are we getting out of it? How is this getting reinforced? Therapists can help you do that. Go to CODA meetings or Al-Anon meetings. And like I said earlier in the webinar, although those meetings were originally set up for people that were, in the first case, married to alcoholics, and later on, just family members of alcoholics, the real issue is what's your relationship with somebody who's participating in self-destructive symptomology. Learning to block and change your patterns. And it takes real work. It's uncomfortable. It's foreign to us. And learning to change our patterns. Learning to own our piece of it and stop it. Make it a project. And you're not going to get it right. You're going to make mistakes all along the way, but you can own it. You can say, what do I own in this? What's my part in the dance? Learning to see the difference between them and you. Learning the difference between the difference between needing and loving. Learning the difference between wanting something for yourself and wanting something for the other. Right? So we start to differentiate. We start to pull apart. That's why the early phases of our program and of treatment are oftentimes where we pull the family apart. Then we work on them to develop a capacity for connection. And that's called attachment. It's also called detachment. It's the same thing. Allowing our children to hurt. The phrase I use, and I used it on a phone call today, was we keep our children small. They don't need our pity and sympathy. They could benefit from our empathy and understanding. But the very first thing I learned about children in wilderness therapy 20 years ago was they're much more resilient than they or their parents think. But because of our guilt, because of our fear of abandonment from our children, which I always think is a great irony, we're afraid of being abandoned by our children. Because of all the difficulty, because we don't take care of ourselves, because we ask others to take care of us, because of all of that, we don't have the capacity then to sit with them and let them hurt and let them be sad and let them struggle. And over time and over years, that becomes a part of the mood disorder, right? They learn not to feel by depressing it. Depression isn't pain. Depression isn't sadness. Depression is hopelessness, helplessness. Depression is, in many ways, the absence of feeling pain and sadness. And so part of what we try to do is normalize it and create space for it. Learn to lean into it. Stop trying to control it. Right? Learn to embrace it. Learn to practice radical acceptance around it. Understand that this is your family's last. The depression is going to be, just like the addiction with the addicted families with addiction, it's going to be your greatest teacher. It's going to be the thing that you learn the most from. Stop trying to convince them that you love them, that you care about them, that you're fair. Let go of all those things. You can't control whether they feel loved. You can only control if you love them. You can't control whether they feel cared about or heard. What you can do is you can learn to hear better and care better. So, but we need them to think that we do these things, and we think that that's going to make them happy and okay. They need us to let it go. They need us just to be authentic. Like I said, learning to love them and they're strong, believing that they're strong. I often think that I'm very, very I'll describe a student, a client, to their parents. And I've had parents say, that sounds pretty pessimistic. I said, no, no, big picture, I'm completely optimistic. And I don't have to think that they're in a great spot right now to have confidence that they're going to be okay. I just had one of my former students from 7 years ago come through Salt Lake and come over and stay with the family. And I told him the first day I met him, I knew he was going to be great, amazing. And I also knew that he was participating in some pretty self-destructive, irresponsible behaviors. And I wasn't easy on him. I didn't ignore it. I didn't recommend he wanted to go home pretty quickly, and I didn't support that. I didn't think that would be best for him. But I knew he was going to be okay, and I knew he was going to be as gifted as he's turned out to be. Part of what parenting is for me, the father of four and the therapist for thousands, is this process of understanding that my children, having confidence in my children, doesn't necessarily just simply mean they're going to turn out exactly how I had dreamed, what I'd hoped. They're going to turn out something altogether different. And that's going to be a wonderful thing. So part of what I have to let go of is my idea of what their life should look like. My idea of what their path should be. My idea of what their truth is, instead of providing a safe place for them to discover it. And some boundaries around that. This is what we talk about, opening doors. That's just listening. The 8 tools for relationship transformation that I did the webinar on a couple of weeks ago, that there's a blog about in our blog. That's essentially it. These are the tools that provide a place for the feelings, for the pain, for the difficulty to come out. We call that containment in therapy. Sometimes parents need to deal with their mood disorder, their depression. And so you can get that treatment in therapy, and some parents might benefit from medication in some cases. So make sure you're dealing with your mood disorder before you do anything with theirs. And then listening to what the mood disorder can tell you. There's great wisdom beneath the anger and the pain, right? And there are great resources available to the depressed person if they can begin to talk honestly, tell the truth about their story, and if they can do that in a safe place. So it's important that before we try to take it away or fix it, that we listen to it. What are the take-home messages? Focus on what you are in control of. You're not in control of others, you're in control of yourself. And if you focus on controlling yourself, you're less apt to be yourself depressed or anxious. And if you focus on yourself, you will have an amazing impact on your children. Make your work and your life your project. Don't make your peace and serenity your child's project. It's not theirs. It's your responsibility. Don't ask them to take care of you. You take care of you. Like I said earlier, accept the lifestyle change rather than looking for a cure. Right? That means that we're not going on a crash diet. It's not an easy solution. I have to develop some new sensibilities, a different sensibility, a different way of relating to my child. And that's going to have benefits in many areas of my life. But it's going to start with my child. It's okay to have boundaries, to have limits, to expect things from your children. It's okay for them not to like it. In fact, I want all of the parents that I work with to stop trying to sell their children on an idea so much and just set a boundary. And then listen when they're upset and frustrated with you without needing to respond or fix that because it's not broken, as a matter of fact. Um, Make sure that you talk to others. The webinars are great, books are great. They don't replace therapy, they don't replace Coda and Al Anon, they don't replace going to the support groups that we offer or the workshops that we offer. Developing vigilance and patience and seeking out medication. And one of the things that happens for somebody that is in a manic depressive cycle is when they're feeling high and up and manic, they feel so good they don't want to be on the medication. One of the greatest variables to effectively treating bipolar is that the individual is consistent with their medication, and we tell them that. And sometimes people need to be on medication forever, for their life. And sometimes there's kind of a stage of life that some of these other factors that I've talked about get worked out and they don't need it later. And most psychiatrists will tell you that it's an experiment, right? We're going to see what works, and we don't know. We're going to take our best guesses. And if something works for a parent, medically speaking, if something has worked for a parent or somebody in the family, oftentimes psychiatrists will recommend that drug because there's a shared organicity, shared genetics there. So if Prozac worked with grandma or dad, then we're going to try that on depressed Johnny who's 16. And then all the while, of course, it not just being one approach and one cure, but multidiscipline, ecosystemic, with all the things that I've described. All right, Michael, any questions on topic? What should a family do with a young adult who has severe mood disorders and their disorder has potential to damage a family outing or vacation? For instance, the older sibling will negatively affect younger siblings during a family vacation. Great question. And there's a lot of, not one simple answer, like do this. Everything I've talked about is kind of approach it that way. I will tell you, it's okay to set boundaries. It's okay if people don't come on vacation with you. It's okay to have consequences and limits. Nest all of that in this compassionate, understanding approach that I'm talking about, that listening approach. So it's not just boundaries. I used to talk about this image. If you can imagine a brick wall with a big ear painted on it, like you can have boundaries and it's okay to listen and figure out what somebody's trying to say, but they can't say it or they don't know how to say it. So compassion, listening, setting boundaries around it is okay, having consequences for the behavior and or not inviting them. It's okay to do those types of things. That's essentially what you all are doing with your kids at our program, is you're saying, you don't get to be on this family outing with us right now. So you're setting that boundary, and that's okay. I think we have this idea that that's disloyal, and we have this skewed sense of loyalty that we need to suffer at any costs because we love them. And our children need us to love us first. That's what they need from us. They need us to love ourselves first. They need a lot of love and attention from us also. But if we don't love ourselves, if we don't take care of ourselves, we don't make that our responsibility, we're going to ask it of them. And that's one of the worst things that we can do. So I'm not going to participate in this relationship in this way. I need certain things in this relationship for it to work out okay, especially with young adults, right? It's okay for me to need things and to get them met. And if you're okay with that, love to work with you. If you're not, I'm going to have to go somewhere else and get them met. But I need them met. I have to have respect. I have to have kindness. I don't want to be yelled or called names. Those are the things. It's not a zero tolerance policy. I'm talking about patterns. But that's my answer, is it's okay to set a boundary around it. Not invite them, especially if they're a young adult. And not just to suffer and ask everybody else to suffer. My child can be very rigid. I'm trying to help him see the difference between being rigid and setting a boundary. Any words of wisdom you can share? That's a good question. You know, Harriet Lerner says that when people first start to set boundaries, that they go through what she calls an obnoxious phase. So part of me thinks valuing the experimentation that he's doing around it, even acknowledging, saying that, yeah, it's easy to kind of make mistakes around it. I think for me, the biggest thing that comes, a boundary is for me, right? It's what I need to feel comfortable in this relationship as a father or as a husband or as a man, friend. And there's certain things that I need. And that's essentially where it comes from. It's not aimed at changing you. It's aimed at taking care of me. There's a wonderful overlap though, right? If I don't feel comfortable with my daughter going out and riding her bike without a helmet, my 7 year old. I'm just not comfortable with that. That also happens to be wonderful for her that she has to wear a helmet. She doesn't like it, she hates it, but I'm not comfortable with it. I'm not comfortable with you yelling at me, right? So I'm gonna have a boundary around that. I'm not comfortable with you smoking pot. I'm not comfortable with you dropping out of school. I'm not okay with that. And I think if we start to talk to our children, all of our children, from a boundary place instead of a here's what this is for your own good, this is what I'm going to do to you to change you. If we can just tweak the language a little bit, all the conclusions will be the same. We'll arrive at the same place behaviorally, but it comes from a place of this is what I need to feel okay, and I don't feel okay about you abusing substances or yelling or being disrespectful or having, you know, doing other things. I'm just not comfortable with that. So that's the difference: is beginning to talk about and own what I need, what I'm going to do, instead of trying to change somebody else. I don't know if that perfectly addresses the rigid things. Part of it, I think, just kind of have a discussion with him and help him learn, and even tell him, give him the quote that I gave you from the Dance of Anger, Harriet Lerner, and say sometimes people go through an obnoxious phase, and I see that all the time with well-intended people. And then also knowing that the rigidness for adolescence, and adolescence I'm describing as because it's a brain development phase too, from 12 to 25 years old. That's how they make sense out of the world originally. It's very black and white, very either or, very all or nothing. And so developmentally, it's kind of appropriate for them to be doing that. So be patient with his understanding, experimentation, and development around healthy boundaries instead of rigidness. Being impatient with it is going to further, he's going to dig in further. Trying to power struggle, trying to convince. It goes from saying, here's what you need to do to, here's an idea I have. I want to offer an idea that I have. Are you open to an idea that I have? This is my thinking on the matter. That's a very different thing than, here's what you need to do. This is how you're doing it wrong. Which in itself is kind of rigid. If a child has not exhibited mood disorders at a younger age, but then they are bipolar when they become a teenager, and they have a parent who is bipolar, and they start acting out like a manic depressive, hitting the wall, or saying they are just like their dad, and they get depressed, they have never shown these behaviors before they were a teenager. Is this something you have seen, or can a bipolar condition come out at a later age? Absolutely. The onset of it is, and again, like I said, developmentally during the teenage years, it's common for these things to be related to the developing brain, the developing hormones, the stresses of adolescence and young adulthood. All of those things are common, and we know that the onset. We know we see sometimes young children with patterns that later then we can see the seeds of being bipolar. We didn't call it that necessarily, but absolutely that's not unusual at all. And then oftentimes, by young adulthood, if we haven't seen bipolar, it's not going to be as common for it to just appear. And I think a lot of people will talk about, I didn't call it that, wasn't fully diagnosable when he was 14 or 13 or 12 or 16 or 17. But I saw plenty of this. It doesn't usually come on to somebody who has no signs of it whatsoever and then later has it. The secondary gain, you can leave it here, Michael, but I was just reading that before it flipped over, is that being like dad is a secondary gain. I have identity, right? I am manic depressive, I am bipolar, I am depressed. Those are all pieces of identity, which is the task of adolescence. So the secondary gain is it gives me some meaning, a framework, a way to understand myself. What if your child has a hard time explaining their feelings and opening up? What techniques can a parent help to do in this area? I actually wrote a blog, It is on the Evoke website. You can go to my website also, drbradreedy.com. Um, and I talk about how to open up. There's actually a chapter out of my book about that. So listening skills, being quiet, saying less, sharing the problem instead of the solution. Like, here's where I struggle in similar areas. I haven't even figured it out yet. Sharing the problem is one way to get them to start to give you advice. But giving space, even being, I remember when this hit me. There's a few other techniques I talk about in the book, like the grocery store lecture, where your lectures. That's not even the right word. Your discussions are 10 seconds long. Like when I said to my son, "Hey, I noticed that I saw some beer cans in the trash, and it's not okay to drink. You're underage, so I'm not going to be okay with that. Now, will you go get the milk?" I don't belabor the point, and I did that. That was a conscious thing. And then he came back, and I just started talking about groceries, and then he started talking to me about it, and opened up about it, and I wasn't even asking to talk about it. So part of what I figured out, and my son was much like this. Number one, I took up too much space. I talked too much. Number two, I noticed when I was patient with his inability to express himself and his lack of talking and didn't ask for it a lot, didn't try to push or prod, that he started talking more. And he started to feel like I was safe because I wasn't impatient with him. I wasn't frustrated with him. And I wasn't overbearing. And that was an adjustment for me because in his early years, everything was a nail and I was always a hammer. And I always thought I thought I could use my therapeutic manipulative tools to pry him open and get him to talk. And I had to make different kind of changes in myself in the process and give him space and be patient with him and before he would do it. But you can read the blog or the book chapter on that for more specific examples as I kind of go after all those. Similar to the previous question, the young adult says she doesn't understand her depression, almost like she has no control over it. She's in bed most of the time. This is so difficult. Absolutely, it is difficult. It's difficult for her. It is their experience that they don't have control over it. Absolutely. 100% true. Their experience is that it's happening to them. And in many cases, that can be true because there is an organic, right, a chemical part of this that doesn't come from choices. And it's different for everybody, right? So people like this need treatment. That's the answer, of course. People like this need treatment. Not outpatient treatment, but inpatient treatment. Primary care. That's what Evoke is. Right? It needs to be that radical of an immersion where they have full-time care from staff and therapeutic staff and therapists. Group activities where groups and peers are giving them feedback, getting them moving, being on a schedule. And it's difficult for a parent to do that for many reasons. Difficult emotionally. And then, of course, you have lives and you can't be a staff member 24/7. And you also, it's probably not healthy for you to be the cop, the policeman, the probation officer, right? That somebody else can do that better than you can. And all of this deserves our compassion, both for the sufferer and for the family members. Thich Nhat Hanh talks about it this way in his book, You Are Here, which I love. And he says, we should look at our depression or our anxiety like we do a little child. We should tell it that we are here for it, that we should hold it like we would a little child in our mind and be compassionate towards that. And it's only through that kind of love and compassion can we fully heal. If we look at, this is me talking now, if we look at it, look upon it in others or in ourselves with hatred and disgust and repulsion, we're going to just bury the symptoms and they're going to crop up somewhere else. So how we think about our children is really, really important. Even more important than what we say or do to them. How we think about them is oftentimes more important. I will set a boundary and say that I am not comfortable with a certain behavior. Then what happens when the child becomes defiant or oppositional? What to do? How do I not escalate the situation in my attempt to hold my boundary? You're going to have to escalate the situation in some ways. It's important. Look at the Dance of Anger webinar when you get a chance. It's one of my recommended webinars, one of my favorite books of all time on boundaries. We don't talk about boundaries. We don't threaten boundaries. We don't philosophize. We don't debate boundaries. We set it. See, it's a win-win in some ways. My boundary is I'm going to set the boundary and I'm going to, if it works, if there's a consequence associated with it, then it works. If the child cooperates, then it works. So it works if they don't cooperate, and it works if they do. Because I still set and live up to and organize the boundary. And in the case of evoke, there are other things. Not everybody has the ability, the resources to go to an evoke, but you folks did, and you can. And so I know what you mean by escalating it in the negative, since you want to get into a yelling match. But the thought that comes into the parent's mind is, oh, well, I'm not going to do this anymore. I'm not going to be in a relationship when you're doing this with you. And so here's what I'm going to do. I'm going to step away, or you're going to step away, or I'm going to send you away. And then I'm not going to be held hostage by my fear that you won't love me or won't forgive me anymore. I'm not going to do that, because you're actually the child, not the parent. And it's me who's supposed to be taking care of you, not the other way around. Learning to hang up, learning to walk away, learning to take time outs. Sometimes we get in patterns that become ruts around oppositionality. And so it's also helpful to shift a little bit and to say, okay, I'm going to try something else. I'll try talking and listening, where, as before, I would come in quickly with a boundary. If I can really learn to deeply listen to what's going on, can that have a different response? So that can be a part of it. I was talking to a parent today and saying, they're saying, when does the child get a chance to prove it? And I said, the child gets a chance every day to prove it. They're getting a chance right now in the program to prove it, right? The letters that they write to you, the phone calls that they have with you, the visit they have, it's always a chance to prove it. So, yeah, we're not going to engage. We're not going to engage it on a peer to peer. We're gonna be as compassionate and listening as we can. We're gonna get better and better at that, and then we're gonna set boundaries, and those boundaries can escalate to something as dramatic as sending you to a vote. And when they become young adults, the boundaries are easier in some ways, because you can just say, I'm not going to do that. I won't talk to you on the phone if you're going to yell at me. You can't live here if you're going to be disrespectful and unkind to other people, or violent, or whatever it is. And then that's the scariest thing that we have to do, is to set a boundary. We look for everything else to do. We definitely want to talk them into it, or threat them into it, or intimidate them, or scare them. And all of those are excuses for boundaries. When a child continues to do dangerous and self-destructive behaviors even after you have told them you're uncomfortable and created set boundaries, what's the next step? You execute more boundaries, right? You just get to the point where you say, this is what it's going to look like. Less talking, for sure, in some cases. Less lecturing, I should say. Less lecturing, less nagging, less threatening. When my son went to wilderness therapy when he was 14, I'd made jokes when he was a young kid about, I have a wellness program, kind of half teasing and half not. And when he was in wilderness, he told me through tears that he hated that. He hated that joke. And it made sense to me, of course, immediately. I had justified it because I thought I was just being cute and funny at the time. But I realized something also at the same moment that he said how much he was angry about it. I realized that the reason I threatened my son about wilderness is so I wouldn't have to send him. I wanted to threaten the boundary, and I had a pretty big one in my back pocket, so I actually wouldn't have to execute it. I was trying to control him by fear. And I put it under the guise of joking about it. But I realized how hard it was for me to set a boundary and to follow through on it. Boundaries are hard. Boundaries are lonely. Boundaries are scary. So the next step is the boundary. The woman in the beginning of The Dance of Anger, Harriet tells a story about a woman who says, I wanted to go to one of your workshops. My husband wouldn't let me. And he put his foot down. And she's like, what do you mean put his foot down? Well, he wouldn't let me. I did everything to try to convince him. I yelled, I argued, I brought up this and that point. And Harriet starts off with this story. Dr. Lerner starts off with the story because her point was, you didn't do a boundary at all. Telling somebody you can't talk to me that way is not a boundary. Leaving the room is a boundary. Telling somebody you won't be treated like that, or they have to respect you, that's not a boundary. That's a discussion. It's the actual follow through that is the boundary, which is, I'm going to hang up the phone. I'm going to walk out of the room. I'm going to take away your stuff. I'm going to send you to a vote. I'm going to ask you to move out. Whatever. Those are the boundaries. When I say to my alcoholic spouse, I'm leaving you, I'm not saying I'm leaving you so that you'll stop drinking. I say I'm leaving you because I'm leaving you. That's the boundary. I can't be in a relationship. Well, if I go and get treatment, will you not divorce me? We'll see. I don't know. Go get treatment. And then we'll talk. And we get confused because we think talking about boundaries and threatening and telling people what we can and won't stand our boundary, those are nothing. Those are just words. All right. Thank you for the question. Thank you for the thoughtful, insightful, challenging questions. If you're in and around New York, there's a private reading November 18th at 7 p.m. If you go to our Facebook page, you can find the invitation there and you can respond to it, RSVP. So, and I'll be there also speaking. We have our next parent support group. That says 4 to 6 p.m. Actually, that should be 6:30 to 8:30 p.m. I don't know why I put that on. Probably because on the calendar it said that, but 6:30 to, oh, that was because it was a Sunday and I just didn't move that. November 19th. This is a Thursday. So let me be clear. Thursday in New York, 6:30 to 8:30 p.m. Los Angeles tonight. So you're either there and not watching this, or the next parent, we just finished the parent Entrada workshop. The parent workshop at Entrada. We'll give you another date here in the next week. And then I have a Finding You that is filling up. A Finding You intensive that's for any adult, any age, young adult on up. It's a 4-day workshop, so it goes over 4 days, 10th, 11th, 12th, and 13th. That'll be led by me. Then Heroic, we have these on the calendar also, Heroic Parenting Workshop and other intensives that we will name later. And then you can email intensives@evoketherapy.com. Pursuits is our high adventure program. These are the 12-step groups we want all of you to go to at least 6 times while you're with us. Don't wait till they get home. Follow us on social media for announcements, inspirational quotes, and so forth. You can get my book on Amazon. Any other questions before we end, Michael? The next webinar will be on eating disorders this Thursday at 7 p.m. That should say Mountain Time. Like I said, I didn't have any way to proof my slides, and that's what usually happens when I do that. All right, folks, I hope these points of contact are helpful. Look forward to talking to you. And again, it's not just eating disorders like the acute ones. It's just what's our relationship with food and how do we use it for self-medication and distracting. So that's something we'll talk about. It's a fascinating and insidious issue because we all have to eat. So, all right, have a great couple of nights, and I'll talk to you on Thursday. Bye-bye.